Welcome to today's Explainer. So, if you're navigating the world of IVF, you already know it's a realm of incredible cutting-edge science. We're talking cellular biology and microscopic precision. But today, we're unpacking one of the most notoriously uncomfortable, low-tech instructions in the entire process, the biomechanics of embryo transfer, and why on earth you are asked to do something so profoundly physical. It's the question literally everyone asks, right? I mean, if you've ever felt the absolute physical irony of desperately needing a full bladder while a doctor presses a rigid ultrasound wand directly onto your lower stomach, you've definitely wondered if this is just some form of arbitrary torture or if it's a true biological necessity. Like, does the embryo actually need that fluid there to survive? Let's dive into the science behind this instruction. Okay, so here's the crucial point. A full bladder is highly recommended, but it doesn't actually dictate the embryo's biological viability. The embryo? It honestly doesn't care if your bladder is full or empty. Rather, filling it serves as a clever, entirely mechanical hack for the clinician. It is a procedural aid, not an absolute biological necessity. Section 1. A simple biomechanical hack. Let's see how this works. A moderately full bladder actually physically alters your internal pelvic anatomy. Think of your bladder like a small water balloon resting right next to the uterus. When it fills up with fluid, it expands and acts like a wedge. This expansion literally straightens out the natural anterior tilt of the uterus, actively pushing it into a much more horizontal position. And why does that matter? Well, it creates a clear acoustic window. It pushes the bowel out of the way and allows the transabdominal ultrasound waves to pass straight through the fluid, giving your doctor a brilliantly clear, real-time visual of the endometrial cavity. And this beautifully translates into the second major mechanical benefit, easing the passage of the catheter. The path from the cervix into the uterus naturally has a bit of a kink to it, but by pushing the uterus horizontally, the full bladder effectively straightens out that kinked pathway of the cervical canal. This makes passing the very delicate embryo catheter much, much easier. It heavily reduces the need for any physical manipulation, which in turn cuts down on physical trauma to the tissue. It actively corrects excessive uterine anteversion or retroversion, basically paving a smooth, straight road right to the optimal drop-off point. So, what does this all mean? All of this mechanics talk leads us to the ultimate goal. This accuracy isn't just about the doctor's convenience or, saving time. The clinical rationale is deeply rooted in the data. Studies actually show that when doctors have this precise, ultrasound-guided visualization to ensure accurate catheter placement, it is directly associated with better implantation and higher pregnancy rates. The mechanical hack literally paves the way for clinical success. Section 2, exceptions to the rule, because actually, a full bladder isn't always the hero of this story. First off, it depends entirely on the technology your clinic is using. As we've discussed, if they use a transabdominal ultrasound, meaning the probe goes on your stomach, you absolutely need that bladder filling for visualization. However, some clinics utilize a transvaginal ultrasound probe instead. Because this probe approaches from a completely different angle, it doesn't need to look through the bladder to see the endometrial cavity. In those specific protocols, zero bladder filling is required. There is also something called the clinical touch method. This is a non-ultrasound guided transfer where the procedure is done entirely by the doctor's feel and clinical experience, without any real-time imaging at all. Now, while this exists, it's far less common today. Ultrasound guidance has become the absolute gold standard of care in most well-resourced clinics, which is exactly why the full bladder instruction remains so common. But here is perhaps the most fascinating exception. Difficult anatomy, specifically a markedly retroverted uterus. This is a natural anatomical variation where the uterus tilts backward rather than forward. In these cases, a full bladder can paradoxically do the exact opposite of what it's supposed to do. Talk about irony, right? The very thing you've been agonizingly holding in, trying to be a perfect patient, can actually make catheter passage harder. If a patient has this anatomy, the sonographer might actually stop the procedure and ask them to go partially empty their bladder just to get a better angle. Section 3, Practical Transfer Day Tips. Let's bring this back to your lived experience. If you take away just one thing from this explainer, make it this crucial distinction. The clinical goal is a comfortably full bladder, never ever a maximally full one. Overfilling is a super common mistake patients make out of sheer anxiety to do everything right, but it actually causes severe physical discomfort. Even worse, it can trigger involuntary bladder contractions and, paradoxically, distort the uterine position you are trying so hard to perfect. More water is definitely not always better. So, how do we actually hit that mark? Well, most clinical protocols remove the guesswork entirely by giving you a specific volume. They will typically ask you to drink between 500 milliliters and 1 liter of fluids a set time prior to the procedure. The standard, actionable steps for your transfer day protocol are pretty straightforward. Step 1. Drink that 500 milliliters to 1 liter of fluid within the exact time frame your clinic provides. Step 2. Avoid voiding or using the restroom before the procedure until you are specifically instructed to do so. And Step 3. Check in with your body to ensure you've achieved that comfortably full status. You're aiming for that perfect Goldilocks zone where you feel the distinct urge to go, but you aren't in agonizing pain. Which really brings us to the bottom line. For standard evidence-based techniques, including typical license practices, the full bladder is an important procedural aid. It's all about giving your doctor the best visualization and easing the placement of the catheter. It's a mechanical tool to deliver the embryo safely, but it does not dictate the embryo's health or viability itself. You are in control, and the biology of the embryo is completely secure regardless of how full you feel. I want to leave you with this thought as we wrap up our explainer today. We spend so much time marveling at the high-tech aspects of reproductive medicine, the incubators, the genetic testing, the microscopic precision. But isn't it absolutely fascinating how one of our most advanced scientific procedures still fundamentally relies on the simple biomechanics of drinking a glass of water? It really leaves you wondering, what other simple, low-tech biological hacks are quietly powering our most advanced medical breakthroughs? Thank you for joining me for this deep dive, and I hope this clears up exactly why that full bladder, as uncomfortable as it is, plays such a pivotal role.